Okay. Thank you everyone so much for joining tonight. We'll let people trickle in, but we do ask as you come in, if you could please mute yourself. Alrighty, so I'll get started. Thank you everyone for joining on this Wednesday evening. This is our fifth annual CT Surgery Interest Day. My name is Gianna DeFelicio. I'm the current president for the Thoracic Surgery Medical Student Association, and the TSMA is hosting this event tonight. So I just wanted to briefly introduce the rest of my team. I'm here with Ethem Ahmed, who is our vice president, Sami Shu, who's our secretary, and Nina Uzogwe, who is our secretary. Oh, I'm sorry, Sammy's our treasurer. And so the first half of this event, which is a two-part event, and the first hour being our faculty panel. So we have four faculty panelists who are all listed here. And they're each going to share a segment about their career and where they see the field going and what they appreciate about where they are right now. So we're really excited to have all four of them speak, and we're grateful for you all for being here today. So without further ado, I'll hand it off to Nina to start off our event.
Absolutely. Thank you so much for that wonderful introduction. It's with great pleasure that I introduce Dr. George Anatakis, who is an associate professor and chief of cardiovascular and thoracic surgery at Dell Medical School, UT Austin. He specializes in thoracic aortic surgery, transcatheter valve procedures, and surgical outcomes research, focusing on socioeconomic impacts in patient care. He's also a graduate at the University of Florida and Johns Hopkins, and he completed a cardiothoracic fellowship at the University of Pennsylvania. Dr. Anatakis has contributed to research improving surgical outcomes and is a dedicated mentor for training future cardiothoracic surgeons. So I'm super glad to introduce him to our community today and sort of take the platform for being able to give this presentation.
Well, thanks, Nina and Gianna and the rest of your executive board and the TSMA for inviting me to participate tonight. I'm really excited to be here and share my perspectives. I think what your organization does is so valuable for students around the country to garner exposure to this really vibrant field, which hopefully everyone will get a flavor for the immense passion that the four of us and as well as the residents that you'll meet later share for this field. So I'm tasked with a few minutes to spend in terms of the pathway that I took to become a cardiothoracic surgeon. There's not just one single pathway, but hopefully it will be a stimulus for just conversation this evening. And so I've got a few slides. Hopefully it'll be able to share, but if not, I'll just talk. Let's see. Can you see my slides now?
Yeah, we can see them.
Okay, super. So thanks again for the kind introduction. So just by way of introduction, I was born in far west Texas, Odessa, Texas, where I spent the early couple of years of my life before we moved to Florida, where there was a larger Greek community in the Tampa Bay area. And as you can tell from my last name, I have Greek heritage, and which I'm proud of, and has influenced a lot of my cultural and religious upbringing as a kid in the Tampa Bay area. I am the oldest of two brothers who are also physicians who did not go into cardiothoracic surgery but are surgeons themselves, and so our relationships with each other, particularly our professional relationships, have been some of the most cherished aspects of my professional life in terms of engaging with my brothers who, well, surgeons are not cardiac surgeons. And so I went to Columbia University, where I majored in history, and I'd be curious, out of the 70 or 80 students on the Zoom this evening, I don't know how many majored in one of the typical core sciences versus one of the liberal arts disciplines. But I chose to major in history, which had always been a passion of mine, knowing that I would have a dense exposure to the sciences in medical school, where I attended University of Florida. And one of the themes that I want to kind of harp on through the next couple of slides is really the value of mentorship. And so early on as a young student, pictured here on the right is the late Dr. Richard Murbach, who was a cardiothoracic surgeon his entire career in the Tampa Bay area. And I first came to know, actually working as an orderly in my summer break early in medical school, working with Dick and his partners in a large cardiothoracic practice, and quickly realized that he had a strong knack for mentorship, for immense passion for the specialty. And Dick was really a lifelong friend and actually died at an early age, but it was very, very influential to me through particularly the early years of my training in terms of being a valuable mentor that I could ask advice to. And later in my cardiothoracic training, actually discuss cases with, and it's just been a really, really valuable influence in me as I've gone through my training and my practice. And so then I chose the customary path, which we'll talk about a little bit in my last slide, in terms of what are the actual ways that one can become a cardiothoracic surgeon. And when I was finishing medical school, there was just one of the integrated programs, and so I chose the conventional pathway, which was general surgery, which I did at Johns Hopkins. And this is an option in residencies, in some residencies, to do a 2-year or 3-year or even sometimes longer sabbatical, which can be in a core laboratory experience. Many folks will choose to get an advanced degree, either an MBA or an MPH. My time was spent in the lab of Dr. Bill Baumgartner, pictured here on the right, where I also did a lot of work with Dr. Ash Shah, who both have been very, very influential to me in terms of not just developing my academic career, but also modeling my clinical practice, modeling my behavior with colleagues and students alike, and both have just been extremely influential mentors to me. Not to mention the various other connections and colleagues that I met along the way performing my general surgery residency. And so after that, I went to the University of Pennsylvania, where I completed my cardiothoracic fellowship and spent additional time with Dr. Bavaria, pictured in the middle, affectionately referred to by many at Penn and now at Jefferson by his initials as Jeb. And what I learned from Dr. Bavaria, many things, are the very, very innovative ways that he has thought about not just aortic surgery, but also a programmatic approach to tackling, a specific condition or disease state, which he really did an amazing job at Penn in terms of establishing a very, very expansive aortic program. And I know we'll do the same now in his new role at Jefferson. And then also, this picture is really important to me because picture on the left is the Dr. Sultan, who I know is very involved with the TSMA as well, who is the chief at Pittsburgh and one of my close colleagues and dear friends. And he and I, in terms of going through various phases of our young attending lives, now leadership roles, are really great influences of support for one another. And one of the things that I really want to emphasize in these few minutes, as you go through your careers, the importance not just of mentors, which I've lined out, but also your colleagues and friends going through many of the similar experiences that you will. And that solidarity, that camaraderie is really invaluable as you go through, what will be immense highs in surgical training and cardiothoracic training, but also, some of the really, really serious, difficult and challenging experiences that we face as cardiothoracic surgeons taking care of complicated and sick patients. So that value of mentorship, but also, seeking those colleagues and friends and comrades that you will undoubtedly encounter along the way in your training will be really, really valuable. after my training, I went to University of Florida, where I built an aortic practice. I also did heart failure, and we had a large department, a mature department, and where I was able to attract referrals from every county in Florida and southern parts of Georgia, with really this culture of yes and availability, and how to be helpful to colleagues and referrings from both within your institution as well as outside institutions, and really had a vibrant practice until I was recruited to Austin to be the inaugural chief of the division of adult cardiovascular and thoracic surgery, where in just a couple of short years, we've compiled a faculty of really expert aortic and heart failure surgeons from many different institutions across the country, and have had a really pivotal role in some of the mentorship of our own medical students at Dell Medical School, as well as some of the residents from surrounding programs in Texas. And so that's my current position now as the chief of the division, where I enjoy still a busy clinical practice with difficult, complex cardiac surgical procedures, but also recruiting and building a team of both other physicians and surgeons, intensivists, as well as nurse practitioners and counselors and genetics and otherwise, to really develop a comprehensive academic program. And so that's my current position. And just to review the timeline to become a cardiothoracic surgeon, which I'm sure many of you are familiar with, and there's not just a single pathway, as I mentioned at the beginning, but traditionally is a 4-year undergrad degree, then medical school, which you all are in. Traditional pathway was anywhere from 5 to 7 years of general surgery training. We know about the now work week hour restrictions, which I think have been very valuable toward work-life balance, maximizing time in the hospital, but also time to be with family and to stay healthy and pursue your other passions as well, which are very important. And then a traditional cardiothoracic surgery fellowship, which can range anywhere from 2 to 3 years. Some people will elect to do an advanced subspecialty training. As I said, mine was in aortic procedures. Or there are now many integrated pathways, which typically are 6 years, occasionally 7 years. There's also some hybrid models, which are a little bit fewer in terms of 4 years of general surgery plus 3 years of cardiothoracic training. That's probably the minority of the training paradigms, and these two are really the most prominent pathways that one can choose and to pursue to become a cardiothoracic surgeon. So I know that was brief. There's other excellent speakers on the panel, so I'll conclude there, and hopefully this was valuable to you all. Look forward to any questions.
Yeah, thank you so much for that comprehensive presentation. I love how you sort of talked about mentorship and also talked about the timeline of becoming a cardiothoracic surgeon. I think one question that I have for you is, you talk about this culture of yes and how can I help? How do you continue that practice in your current position as chief of cardiovascular surgery at Dell Medical School?
Yeah, great question. And I think, one is just always, this notion of being available and also affable in terms of, kindness with referrings. It's also important, I think, as folks evolve into more leadership positions, to be intentional and cognizant of developing, the other faculty on your program. And so, with erstwhile and eager junior faculty, when appropriate, incorporating them into that, culture, and also being thoughtful about when to, either pass off appropriate cases, or do jointly together to embolden them to, have the confidence to take on more difficult cases, and also feel very invested in the program. And so as I take on more and more sort of administrative responsibilities, bringing in all the faculty has been really, really helpful, particularly in the last couple of years in my latest position toward maintaining that culture, but also being able to develop younger faculty. And also, of course, at the center of all that we do, making sure that the patients get excellent care.
Absolutely. Thank you so much for talking about that. I kind of wanted to open the floor to our other panelists to see if they have any questions or follow-up comments. Okay, seeing as there is none, thank you so much for your time, Dr. Anatakis, and we'll move forward with our next panelist.
Absolutely. Thanks for having me.
Thank you, Nina. And just to let everyone know, if you do have any questions throughout the event, if you could just put them in the chat, and we'll have time at the very end for a student Q&A with everybody. But please just enter those into the chat in the meantime. So up next, I'm glad to introduce Dr. Dure Gerard. So he is a thoracic surgeon and an associate professor of clinical surgery at the Hospital of the University of Pennsylvania. Dr. Gerard is one of the founding faculty members of TSMA, for which we are very grateful for him. And he is also previous president of the Eastern Cardiothoracic Surgical Society. So thank you so much for joining us today, Dr. Gerard. And he'll be talking today a little bit about what he finds to be the most rewarding part of his job.
Thanks, Gianna, and thanks for the organization to invite me. I'm going to share my screen here. 1 second. What it is? Can you see my screen?
We can.
Okay, do you see the full screen?
Yes, we see the full slide.
Awesome. Okay. Well, thank you very much for inviting me. And, that's always an interesting question and kind of gives you time to reflect what's the most rewarding part of your job. And so, I think, some introspection is needed to really answer that question. And I came up with a couple points that I think are important. You're all very dedicated to your future profession, and maybe some of you don't even know if they want to really do cardiothoracic surgery or a different specialty. But I think you all have in common to be very passionate about medicine and have an interest in helping others. I think it is, as you might have already experienced as a medical student, when you carried out some tasks that you really can make an impact. You can make an impact and contribute to your team, and I think that's very important. And that really contributes to feeling rewarded for your hard work and for your dedication. As you probably also have experienced, it's really important that if you're a first-year medical student, a second year, a third year, sub-I, that you have certainly experienced growth in your responsibilities and some changes in your contributions to the team. And I'm sure to keep in mind, and what George said is very important, also keep a balance of what work-life kind of equilibrium. That is very important these days. I think we all feel rewarded in our job if we get recognition and appreciation for what we do. For being in a faculty position, it's important to have financial stability. That sort of gives you a base for planning your family, your retirement, whatever is important to you. And overall, I do believe that job satisfaction is also driven by a positive work environment, a culture in your institution, and all of those really contribute to making for a rewarding career. Well, if you kind of Google it or whatever, what is job satisfaction? Well, if you choose a job that you love, you'll never have to work a day in your life. I don't think that's true. We all work very hard. You always have to work. You still can be satisfied, but I think it certainly makes it much easier if you have a job that gives back a lot to you. Let's look at some of the data, and I'm happy to get some comments from the other faculty. But this is the 2019 survey of the Society of Thoracic Surgeons, and it's been done since 2003. And overall, if you look at the left-sided column, if you look at, this was on a scale from 1 to 5, and a now 17% were extremely satisfied with their career. Another about 38% were very satisfied, which makes up for a total of about 55% who were very satisfied or extremely satisfied. And that probably hadn't changed too much, in the past, but I think there's some improvement, certainly sort of in the middle of the pack. There was still about a third who were satisfied, and if you look at the trend of cardiothoracic surgeons not being satisfied, that has fortunately really dropped from the initial survey in 2003 to now only about 14%. And very, very fortunately, the number of not satisfied faculty was very low at 2.9%. It's very different from the initial survey taken in 2003. And I think back then, cardiothoracic surgery was somewhat in a crisis because the numbers of cases have gone down. There was a lot of PCIs done, and I think that was an area where it was an impetus actually for our specialty and mostly for cardiac surgery. And I really applaud cardiac surgery, cardiothoracic surgery, and I'm a general thoracic surgeon. They really reinvented their skill set and their sort of expertise and what can be treated by surgeons, which, and I don't need to tell you too much about it. Other members of the faculty can talk about it more. Is really the catheter-based skill set that really has increased the repertoire, and I think it really reflects sort of the outlook in the future, which is also reflected in the job satisfaction. It should be kept in mind that at the STS 2019 Workforce Survey, there was still not an insignificant number of respondents that felt they had signs of burnout or depression. So, certainly something to keep in mind, and it goes back to the work-life balance and your positive work culture and everything that George is doing with his faculty and so forth. So really important part of being in a department division or in a health system that really pays attention to these important items to keep you going. This is a different survey. It's probably a little bit outdated, but it looked at career satisfaction, and it's kind of the question was somewhat binary. Would you choose your career again, yes or no? So obviously that's kind of a drastic sort of question. So and back then we had much less women in the field of cardiothoracic surgery, but the good news is in this survey from 2016 that the majority of respondent would certainly choose a career again in the field of cardiothoracic surgery. On a side note, I think that the interest of in cardiothoracic surgery among medical students and residents has gone up. It's a very competitive field, and I think it speaks a little bit to the bright outlook of our specialty, and really the hard work of the giants in the field on whose shoulders we stand. And George trained at Penn, and there's many other outstanding institutions. And I think our specialty has really reinvented itself and has a very bright future. And I think Rita will talk to that effect a little bit more, so I'm not going to dwell. What are the main components? And I think if you talk about what is rewarding, it's good to reflect on the main components of our job. And obviously, it's clinical care, excellence in clinical care. It's a trifecta of academic surgery in various compositions. It's education. That's the reason we're here today and tonight, to really pass on some of our experiences to you. And to entice you to pursue a career in thoracic surgery. and be and really be good colleagues for you in the future. Obviously, some of you do varying amounts of research. I do some research. I don't have a lab. Two of my partners have a lab and have NIH funding. I don't, but I'm a collaborator. But I think besides the main components of your job, there are other components that are very important, and some of them are leadership, global surgery. Some of you have an interest in global surgery. Some of you are very engaged in different societies. And some of you are advocates for certain, like aortic disease or some orphan disease and so forth. So there's many ways to be engaged and sort of put the puzzle together that makes for a rewarding career. Um, well, I also think that, and what I have observed, that the mix that makes you happy might change over time. So your first job, you look for something very different than in the midst of your career or later in your career. So the mix of the trifecta of academic surgery, surgery, leadership, education, and research might change, and maybe after a while you become more active in leadership. And George has alluded to this a little bit, what his progression has been in his career, and I'm sure he derives a lot of satisfaction or rewards from this. And so again, keep in mind that things change. Your perspective will change, and so you have to be flexible. You have to be open-minded. And I think it gets back to on something I don't want to dwell too much, but I think you do need a mentor, you do need a sponsor in your career, and you need to periodically evaluate what your goals are and where you want to go. And change is good, setting new priorities and so forth. So I think that's the part of our career that's very rewarding as well, that we change directions. We are not set forever in the same sort of pathway. And well, I haven't answered the question what's most rewarding to me right now, but at this point in my career, sort of mid-career, I hope, it's really my clinical practice at Penn and at the Veterans Hospital, as a matter of fact. And also, I'm heavily involved in education. We do have a traditional fellowship in cardiothoracic and thoracic surgery. We also have an I6 program that was initiated by Dr. Michael Acker initially I think it was conceived in 2008 and kind of got off the ground in 2009 or 2010. So education is a big part of my what really rewards me every day, and seeing our residents coming through. We have a very large group of general surgery residents who are interested in a career in thoracic surgery, and we organize dinners for them and all sorts of activities and mentorship programs, and I think that's been very rewarding. I'm a research collaborator, which gives me some joy. I don't have a lab again, but I do collaborate in a lot of studies with my peers. And at this point, I've found a good sort of work-life balance with my family, my children, and my sort of what I can do at work, and sort of keeping everyone happy. I also get very good leadership in our division, which is important, and that was really a big change in the last couple of years, having good leadership in our division and working, that our division works very well with cardiac surgery, and sort of having a positive outlook of what our goals are in the short term and in the long term. All of that together makes for what is very rewarding at this point. I think things change over time. There might, we take on new challenges or new opportunities come up, and you sort of try to be flexible, and again, kind of relish your camaraderie and looking forward to what the field brings to us. So that's all I have to say.
Thank you so much for sharing all of that, Dr. Jarrar. I really appreciate hearing not only just the personal anecdotes, but also you threw in some hard data in there. So it's a great mix of both. And I also think it's really interesting to evaluate, like you were saying, how satisfaction and passion kind of develops throughout a career, because I think what gets you excited when you're at our stage ends up being very different about what you may appreciate when you're really fully into it. So I would love to hopefully circle back on that in a little bit. I think in the interest of time, we might need to go on to the next segment. But thank you so much for sharing all of
Sure.
that today, Dr. Gerard.
Do I have to unshare or can you do that for me?
Ooh, you might have to do it, but I will attempt.
Okay. Um,
I
Yes.
just,
okay,
Oh,
good.
there you go. You're good.
Thanks.
Thank you, Dr. Jarrar. We'd like to transition now, and we're very fortunate to welcome Dr. Rita Molesky with us today. Dr. Molesky is an associate professor of surgery at Yale University with a focus on educational, critical care, and mechanical support. She's also the program director of the Traditional Cardiothoracic Surgery Fellowship and currently serves as a member of our advisory board for the TSMA. Welcome, Dr. Molesky. It's so good to have you on with us tonight.
Thank you very much. I'm going to try to share my slides as well.
Sure.
So let's see how successful I am here. So can you see that?
It's loading. Yep, there it is. And just for our audience, our topic question right now is with emerging therapies and technologies, how can applicants best prepare for practice in the field in the next 10 to 20 years?
So I would like to thank the TSMA for inviting me to present today. And as the, how should I politically put it, the most mature person on the panel, I think I have a great insight into where we came from and where we're going. So it's impossible to talk about new technologies and new techniques that will evolve in the future without knowing where we came from. Because of all of cardiothoracic surgery has built on the shoulders of the pioneers who came before us. And I just want to talk about perspective here for a minute. So when I was growing up, this was my perspective of space. Star Trek, Lost in Space, my favorite Martian with the little tentacles. But this is what we thought space was. And never in a million years would I've ever thought that I could see a rover on Mars. So what you need to think about is what is going to be in your future, not only in cardiothoracic surgery, but where will we be living in another 50, 60 years in your lifetime? So I want to take this all back and again, talk to you about where we came from and where we're going. So this is a cardiopulmonary bypass machine, which is what we use today. So here's a test. I bet none of you thought you were going to have a test this evening, but here's a test. So this is a operating room in 1954. Dr. C. Walter Lillehei here is operating on a patient doing a VSD repair. As you can see, there's a bunch of doctors standing over the scrub nurses here, anesthesia's over here in the corner. You can see there are windows, and I can remember when there were windows in the operating room that you could open, and a little radiator here. So my question to you is, where's the cardiopulmonary bypass machine? Just take a look at it for just a second. Where in this room do you see the cardiopulmonary bypass machine? Well, in the essence of time here, I'm going to tell you, it's right here. So the 18-month-old's father was the cardiopulmonary bypass machine. There was a cannula placed in the 18-month-old neck. The blood went to the father, went through his heart and lungs, came back into the ascending aorta of the patient. This is in 1954. But think about this. Doesn't look a whole lot different than VA ECMO, does it? So VA ECMO was 70 years in the making. Cross circulation in 1954 is what we utilize now as cross circulation for VA ECMO. So when you're thinking of where we're going in the future, or where techniques and technology will be in the future, and how you can start to look at it now, think about what are the procedures, what are the techniques that we utilize now, And how will those change to benefit mankind in the future? Here's another procedure. This is the Weinberg procedure, was done in 1946, 20 years before they had before they had bypass, venous to arterial bypass. What Dr. Weinberg did was he took the left internal mammary and then made an incision into the left ventricular muscle and just shoved it in there. And collaterals grew, and you can see the collaterals growing into the IMA here and going into small branches. Well, not a whole lot different than the left internal mammary to the LAD bypass that we do today. So what was done in 1946 resurfaced in the end of the 1960s, and we still utilize it today. So again, you have to have this perspective of where did we come from to know where we're going. So do not discount technology and embrace it. Embrace it now as a medical student. Embrace it as you become a resident and as you become a junior attending. When I was a resident, my first year, they were doing research on endographs. And I thought, how stupid is that? You just open up the belly. This will never work. Embrace technology. Cardiothoracic surgery has always been at the forefront of medical technology and medical therapeutics. So you need to follow that. Well, you may ask yourself, how do you follow that? Which is really the topic of this talk. So what is your key to success to be able to follow technologies and therapies as you go to the future? Well, I think this has been mentioned in the last two talks. You need mentorship. So you need to identify a cardiothoracic mentor now. Now, as a medical student, that could be your chief resident, a cardiothoracic resident. It could be a junior faculty member. It could be a senior faculty member, whoever you have a relationship with, who will help you identify where you are now and where they think the technology will go. So I have four suggestions for you. The first one is to trend new technologies and new techniques. Identify a mentor and discuss those technology and techniques with them, where you are now and where they think those new techniques will be going. The second thing is technology follows pathophysiology. Identify major pathophysiologic areas. So you can't just sit down and think, well, gee, where's the technology going to be in cardiothoracic surgery in 20 years? You cannot think of it as cardiothoracic surgery. You have to break it down in specific pathophysiologic focuses to be able to really wrap your head around it, to grasp the history of it, the perspective of it, and where it's going in the future. So knowing the physiology is the key to knowing how to approach these new technologic advances. You start out by looking at an aortic focus, a valvular focus, heart failure, or robotics as a platform, and biologic therapies, which are becoming more and more important in oncology. So for example, this is what thoracoabdominal surgery looked like when I was doing my residency. It has evolved into the thoracic TVARS or percutaneous approach. That has evolved into a more specific physician modified endograph. So where will this be in the future? This is the way to approach it. Find a specific pathophysiology and watch as it evolves. Another type of pathophysiology to watch, or another focus, would be heart failure. When I was going through my training, this is what a ventricular assist device looked like. It was pneumatic in nature, meaning it was a pump with air. It sat outside the patient's body. So they had two big motors on the outside of their body, and they had to push, this is the motor, they had to push the motor around like a walker. They were never detached from this. They slept, showered, and walked with this everywhere. Few of them went home. Now it fits in the palm of the hand. It's a centrifugal device that fits in the palm of the hand, or even smaller. It's an axial device that can be placed through a femoral artery into the left ventricle or the right ventricle. So taking this perspective, again, where will this lead us into the future? So take what we have now and think about where it could go in the future. Valve is the same way. When I was a child, when I was growing up, this was what an aortic valve looked like. It's a Star Edwards, and it's called a ball and cage. So there was a cage, and as the ventricle pumped, blood would come out, the ball would raise, and as you go into diastole, the ball would fall back again. Now we have both biologic and mechanical valves. We do valve repairs. It's evolved into doing valve repairs or percutaneous valves. So again, identify pathophysiology and identify how that is progressing both through a technique and technology. Where will it be in the future? And then the robotic platform as well in both thoracic as well as cardiac platforms. Number 3 is to trend those pathophysiologies, which are highlighted at national and international meetings, as well as societal websites. So what do I mean by this? Well, follow the websites on the AATS website, as well as the STS website, to find out where the meetings are and the agenda, what is being highlighted at those meetings. And if you are fortunate enough to be able to go to those meetings, for example, by applying to be shadowing and attending at the AATS, or applying for a scholarship for the STS for looking toward the future, and you go to these meetings, make sure you visit the exhibit halls of these major meetings and look at all of the different companies and follow the topics of the sessions as well. Other things that you can do is to look at the different courses. We'll look at the different courses that were actually offered at this year's STS meeting. TVAR 101. Well, look at the names here. Dr. Arnatokas, Dr. Sultan, and a lot of the people that you will know here are actually teaching the new technologies. So when I say identify a mentor, identify someone who is in cardiothoracic surgery at your institution, at your medical school, or you can email someone and ask them, would you mind answering a few questions for me as far as mentorship? And you can go forward with that. But this is all highlighted at these national meetings. Something else at the national meetings are different sessions that the companies have highlighting their new technologies. So whether it is thoracic, or it could be something like heart failure, all of these new techniques and new technologies are highlighted at national meetings. Now, as a medical student, are you going to go every year? No. But again, you can apply for the Women in Thoracic Surgery, the STS, looking toward the future, or the shadowing and attending through the AATS. And perhaps once in your 4 years, you're able to go. Or you can ask your mentor to bring back information. Or if they have been to the meeting, sometimes they also have the ability to log on to the video of that meeting, and you can see some of those highlights. So again, having a mentor, you can ask them these questions. And there are now pre-courses at these meetings that you can go to, for example, lung cancer or the aortic universe, birth to adulthood. There are also webinars that you can find on the different National Society websites. This one just follows the topic of this talk, innovation, where's thoracic surgery going? And our webinar just telling you how to stay relevant on the cutting edge, what junior surgeons need to know, and how to best partner with industry. So here is a methodology to keep on the cutting edge of innovation in thoracic and cardiac surgery. And number 4 is to identify who is conducting random controlled trials or clinical trials. And you can do this by actually looking at major journals, either the Journal of Thoracic and Cardiovascular Surgery or the Annals. And if you look at these journals, just look at the table of contents, they actually break it down into different pathophysiologies. So for example, if you're interested in aortic valve, it breaks it down into the aortic valve pathophysiology. If you're interested in mechanical circulatory support, you can learn what's going on, what's new, what kind of trials are going on in each one of these different pathophysiologies. So if you are looking to find new and inventive ways for cardiothoracic surgery, technologies and techniques, then you can either, if you're looking on Mars, or if you're looking in a galaxy far, far away, follow your quest to new cardiothoracic technologies, and may the force be with you, young Jedi. Thank you.
Thank you so much, Dr. Molesky. That was a really interesting and comprehensive presentation, and thank you for sharing those tips with us. I think it was Wayne Gretzky that said, like, don't skate to where the puck is, but skate to where it's going. I don't know anything about hockey, but I think that quote really applies here.
Yeah.
It's really an exciting time for us to really be entering, and I think there's going to be a lot of follow-up questions. Just in the interest of time, we're going to keep moving forward. But to all of our students, please put your questions in the chat and keep them in mind for later.
All right. I am going to go ahead and introduce our next panelist. Perfect. We are so pleased to announce that It's my pleasure to welcome Dr. Tara Karamloo. Dr. Karamloo is a pediatric cardiac surgeon at Cincinnati Children's Hospital and a professor at Cleveland Clinic Lerner College of Medicine. She also spearheads the Akron Children's Heart Center as a part of the Akron Children's and Cincinnati Children's collaboration to enhance complex care in pediatric cardiology and cardiothoracic surgery. Dr. Karamloo will be talking about what her subspecialty entails and what she enjoys most about being a congenital cardiac surgeon. Take it away, Dr. Karamloo.
Awesome. Okay. All right. Let me go to full screen. Okay, you guys can see this, correct?
We can see it.
Yep. All right. So, I don't want to say anything, but I always save the best for last. And if you ask most CT surgeons, most of them said that they wanted to be congenital surgeons, but they chose something else in the end. So there you go. So what do I love about my job? Well, there's a lot to love about it. I have one disclosure, but nothing relevant to this talk. So I think some of you probably know me, some of you probably don't, but since congenital is sort of the small stepsister, who am I? I'm a pediatric cardiac surgeon. I'm also a surgeon scientist, so I'm very involved in both translational and clinical research. I'm a patient and physician advocate. I am on the board of many of our patient advocacy organizations, and actually they're funding grants now, so it's a good space to be active within. I'm also a champion of advancing women. We talked about the changing demographics. Who knows whether DEI will go away totally, but I can assure you that women in CT surgery are going nowhere but up. And I am very proud to be advancing leadership in women in our field. And I have to admit that I love the field of Prada, and I'm headed to the Milan Fashion Week with my daughter, who's pictured over here, Lourdes, who's now 15, and to hang out with some of my besties. And it's you got to have work-life balance. All right, so where I work, I just left the Cleveland Clinic, which I love dearly. So I will only say good things about my peeps at the clinic and the Cleveland Clinic. But better opportunities arose. And so now I am at Cincinnati Children's, and I spend a lot of clinical time at Akron Children's running their heart surgery program. My office, well, it's an operating room, so that's your best life ever, is not being in clinic all day. We really, as congenital surgeons, see our patients preoperatively. We don't often see them postoperatively. We leave that to our pediatric cardiology colleagues, so even better. Why pediatric cardiac surgery? Well, congenital heart disease is actually the most common birth defect. So as long as people are having babies, job security is there. It does affect 1 in every 100 children, sadly. The anatomy is variable. I loved microvascular surgery, and I loved coronary artery bypass grafting because it was technical surgery, but I really craved variation, and there's an endless spectrum of different phenotypes. Talking about Lillehei and the VSD, every VSD is different, and congenital heart surgery is really about mastering the heterogeneity and bringing a creative focus and innovation to this. And yes, CT surgeons have been at the heart of innovation, but I would dare say that many of the most innovative ones were actually congenital heart surgeons. So I think we come from a very, very proud legacy, and it is really just the best specialty. Small group of people, there's about 105 of us in the US. So it's a small community, which can be good or bad. It's a little bit like being back in high school again. You know everybody, everybody knows you. But it's also wonderful. I can send an email to anybody in the field, and I know most of their phone numbers, and you get a response that day back from usually people you know pretty well. So getting back to why I love my job, the patients. We operate on patients from fetal life through adult life. And I think that this is the only field where you get to see your patients grow up. And I often tell them at the end of an operation that I hope I never see them again, but I love Christmas cards. And that really is true. If you have to see them again, it usually means that something went not so good, or they need a repeat surgery, unless it's a planned sequence of operations, which many of our patients who are not born with all of the pieces of their heart look forward to a life of repeated interventions. But when you query those children into adult life, they actually score higher on quality of life questionnaires. So children are resilient, and there's a lot of lessons that I learn every day from my patients. I do it because it's about making it count, and children are at the center of every community. And I saw Sam somewhere, but I didn't know if he was going to be here at the CHOP meeting. But qualies gained, most qualies gained, and Sam, Anish, and Yvette can speak to that. All right, this is going to be a montage of photos. If you weren't convinced that congenital is really where you need to focus, I'm going to show you some photos that I think will convince the remaining dissenters. So why pediatric heart surgery? I mean, look at this. Look at these patients.
Yeah, good night.
Look at this. Babies, like it's the best ever. Moms, young dads, adults, anesthesiologists, just the best families. And sometimes when there's no nurses around, you actually get to do a little baby time. So that's good for all of us moms. All right, what else? The people. Dr. Spray, one of my close friends and mentors, and he really has helped shape my career and helped me through my adult cardiac surgery residency when I was first rotating on congenital, and I would call up Dr. Spray, and like how cool to get advice from him. Ross Ungerleider was my first mentor when I was a general surgery resident, and he really taught me that no idea is too big. He was really just amazing. And I left his office with every meeting just feeling like I can do anything. And that level of inspiration and confidence has really been something that I hope to share with the future generation. And he's still practicing today. Sadly, Dr. Spray retired with his $9 million at the end of his career as his last paycheck, I guess, and is living his best life in the Blue Mountains. Go, Dr. Spray. John Nigro, after my first double switch operation, and this is the family, Rick Oye, one of my dearest friends and mentors at the University of Michigan. And he's been through a lot, and it's just the best people. All right, Cleveland Clinic references, the clinic family. There's a lot of men in that picture, but there's a girl in pink there. I love this photo. And right next to me is Lars Svensson, who was also one of my strongest advocates and best friends and mentors. Colleagues, my fellow, some of our nurse practitioners, Dr. Potes will be graduating. She's the second Cleveland Clinic congenital fellow. And one of my fellow, when I was doing my fellowship at Seattle Children's, Mike McMullen, this is in Vail, and Baha Al-Sufi, who was one of my, again, George talked about people who can be mentors. He was a senior fellow when I was a general surgery resident. And most important, the future surgeons, Betty Cherew, power is a gold. And then at the, I think STS or AATS, hosting a bunch of AATS and STS young aspiring CT surgeons. I think Sam's in that picture somewhere. And the science, congenital is a small field, and Dr. Beauvais and Dr. Spray. And you get to participate, even when you're a resident, a student, the congenital room is small enough that it's always welcoming. The community, talking and, wearing some great Prada, rocking a boa there. The skill set, it fits. You have to make sure that you are up for the job. And congenital heart surgery is tough. Things are small. How big is a baby's heart? Well, if you think it's the size of your fist, look at a baby's fist. So it takes a lot of dedication, a lot of dexterity, a lot of creativity, but it is a journey that has been well worth it. I'm going to, what's my day like? Well, I threw this in there. Most days for all surgeons are about the same, but I want to emphasize what the other panelists talked about, that all congenital surgeons are academic surgeons. And so you have to do everything, educate, science, and clinical excellence. It's really, 7 a.m. to 7 p.m. Yeah, but here we are at 9 p.m. still going. I just wanted to show this as the last slide because I'm not going to talk about education, but I'm happy to talk a lot about it. And congenital fellowship landscape is very different than many of the other fellowships. There is, 6 to 8 people and about 6 to 8 spots every year. There are more and more, but their quality of programs is not the same. So choose your fellowship wisely and choose your first job even wiser. And to do that, you need great mentorship. And as my last comments, I will say that your career is precious. And all the equity that you have built in it, and you will build in it, don't waste it on a bad mentor or somebody who doesn't care about you as much as you care about your patients to be. So choose your mentor and your sponsor wisely. Thank you very much.
Thank you, Dr. Karamlu, and especially for those wise words and those wonderful pictures. And actually, while I have you here, we would like to share this with our audience. We are so pleased to announce our first ever student scholarship sponsored by our advisor, Dr. Tara Karamlu. The TSMA Tara Karamlu Conference Scholarship will be given annually to one TSA member who is presenting a poster or oral presentation at any CT surgery-related conference. You will have the chance to apply for the scholarship to cover the cost of your conference travel, and this scholarship will be awarded with an emphasis on supporting students with low resources and a lack of exposure to CT surgery at their institution. Any TSMA leaders, including executive board, committee chair, committee members, will not be eligible for this award, as we are seeking to give this to a true TSMA member solely. But TSA members, don't worry, we're actively working on funding opportunities for you as well. And this scholarship is live now, as you all are the first to hear about this, and the deadline to apply for this scholarship is 11:59 p.m. EST on March 21st. So we would like to extend a huge thank you to Dr. Karamlu for our first ever scholarship. And
This is going to be awesome. Thank you so much. And please apply. And we can't wait to welcome you guys to our conferences. And you can, present some science or meet some folks and have some good dinners and some good wine.
Well said. Thank you so much, Dr. Karamlu. I'll pass it off to Edhem and Nina now.
Thanks, Sammy. Gian, I think you were going to announce something for the audience members.
Yeah, just because we're already here at 9:05, and I'm not seeing any questions at all in the chat, I think we're going to just move on to our next announcement, and give a huge, huge, huge thank you to all of our faculty panel members. I mean, listening to you all was really wonderful. You had great insight to share, and it's always just a pleasure to learn from you all. So thank you so much. I think everyone really did a great job of kind of setting up this next thing that we want to show you all. So we heard a lot from Dr. Molesky and really everybody about resources that you can use and steps that you can take in order to really start exploring a career in cardiothoracic surgery. And so we put together a bit of a guide, especially for students who are just starting out and figuring out, is CT surgery something that I'm interested in pursuing? So it's a step-by-step kind of manual of goals that you can set for yourself throughout your medical school career in order to really explore cardiothoracics and whether or not this is the right career for you. So we're going to send this out as a PDF. It'll be on our website, on our Twitter, and through our email listserv to everybody. And it's something that you can just kind of keep yourself accountable for, or like we were talking about earlier with Dr. Gerard, finding a mentor and having them keeping you accountable as well. And really just trying to get yourself in the best spot to look at, is this the right thing for me? So there's a lot of links of how to get all of these things done too. So hopefully this can be a really good resource for everybody. And we tried to make it accessible for programs that also don't have their own home cardiothoracic program. So there's a lot of online resources in terms of watching surgeries online or mentorship programs where you can get connected with a mentor who's not at your own institution. So hopefully this is useful for everyone. And if you have any thoughts of things that we could add to this that would be helpful for your own journey, please let us know. We're always trying to build this, and we're glad to be able to provide this at this point. So we'll send this out to the registrants, and it'll be live soon. But again, just wanted to give one more big thank you to our faculty. It was great hearing from you tonight. And at this point, we'll start transitioning over into our resident Q&A, a resident and fellow. So thank you all so much. I'll let you get on with the rest of your nights now.
Thank you all.
It was so great to see everybody and all the other great faculty. Wow, what a group. You guys are fantastic.
Thank you very much for the opportunity to give some insight to all of you medical students. I really appreciate that.
Echoing the same. Have a good evening. Great program this evening.
Thank you all so much. And to our students, we're only halfway done with the event. Right now, we're about to transition to our resident panels. And today, we're very lucky to welcome 16 residents and fellows from all over the country who have really volunteered their time today out of their busy schedules to share some insights from training. And in a few moments, we're going to create a few breakout rooms where we'll be covering a number of different themes, including away rotations, how to survive intern year, the nuances between I-6, 4-3, and traditional training programs. Is CT surgery right for me? Life as a resident, research during training, as well as residency applications. So I think the plan right now is to do 3 15-minute sessions in each breakout room. As soon as they pop up, you're free to join whatever you're most interested in. We do politely ask that at the end of the 15 minutes, you do relocate to a different themed room so that everyone really gets a chance to get some time with our trainees. If there are no further questions, I think we'll start opening up the rooms.
So the rooms have been opened. You should be able to sort of figure out which rooms you want to go to out of the 6 that we have here.
Thanks, Nina.
And residents, if you have any questions about which room to join, just shoot us a message and we can clarify.
It's always so nice seeing the participants go down as people join.
Should I continue recording? Or pause?
I think we can pause for now.
Waiting for everyone to trickle in from their rooms.
Laura, hello.
Hi.
Are we allowed to talk on this, or is
I
it
don't know.
normal still?
Oh yeah, you guys can go for it. We're just gonna say a goodbye to everyone, but if you have a moment you want to have, please.
Oh no, I always want a moment with Dr. Dikiakio.
Hey, back off. Laura's mine now.
No, I don't even know who you are, but you're wrong.
So Joe, you have to tell, so Jad is one of the PGY3s here at Cedars. I'm sorry, he's been helping me with all of the ECMO cannulations this week.
Oh no.
You're gonna have to teach him how to say my last name. They don't know what to refer to me as next year.
It's Dikiakio.
No, it's Dikiakio.
I know it's impossible. I have to look at it on my phone every time. It's brutal. But you're very lucky. I wish I could have worked with her a lot more. That's awesome.
Another plug to apply to Cedars, everyone.
Yeah.
All right, let's let them say their goodbyes.
All right. Yeah. Sorry, guys. Thanks for having us here.
No, thank you all for coming, really. I think I was only able to join a few of the breakout rooms, but the ones that I was in, a lot of really great insight was shared. So thank you all for your time, especially all of the East Coast residents, for which I know it's nearing 10 p.m. now. So that's a big sacrifice. Thank you so much. Nina, if you want to close us out.
Absolutely. Thank you again to all of our residents for being at our panel. We really appreciate your time, your efforts, your words of wisdom. I learned a lot of different things from different sessions that I attended. And so just be able to hear your caliber, also to hear your transparency and what you've been through and how you're passing on the baton to the next generation is really amazing and really means a lot to us. So thank you so much for your time during this evening. And to our students, thank you for attending our 2-hour session. We really look forward to sort of seeing how we can grow together as TSMA. And we hope you enjoy the rest of your evening. Bye, everyone.
Good luck, all.
Good evening.
Thank you so much.
Thank you.